I will be partially hosting this health panel with Deborah Morgan of the Health Committee. So I'm just going to do some very brief introductions. We are talking about COVID-19 and the vaccination, as well as Black maternal health, two areas of core concern here in New Jersey, right? Both should be at the very heart of this discussion. And as we learn, as things are starting to come about, we learn more and more about COVID-19. There's a great deal of crossover when it comes to the concern for pregnant women and the way they do worse when they contract the virus versus someone who's non-pregnant. But those things will all be covered in today's discussion because we have none other than Dr. Chris Purnell. She is the Chief of Strategic Integration and Health Equity Officer in Newark, New Jersey, and as well as Christine Ivory with the Prematurity Prevention Initiative. She is the project director. If you've not heard either one of these ladies, like strap up because you're getting ready to get a great deal of factual, not fake news information when it comes down to both of these topics. Dr. Purnell, I don't want to steal her thunder because she'll share so much about her, but I had the opportunity of moderating a panel with her earlier in the year with Salvation and Social Justice, where she set the record straight on facts concerning the COVID-19 vaccine. So without further ado, I'd like to turn it over to Deborah Morgan, who will take it from there. We'll do a more formal introduction of our two speakers, including their bios, and we will jump right into the topic. And just know there will be Q&A at the end, so please use the Q&A box and we'll closely monitor it during this time. Thank you both for being with us today. Very excited to have you.
Thank you, Crystal. Good afternoon, NAACP family. I am happy to be here this afternoon talking about two important subjects. I wanted to take this time to send healing prayers to our chair, Vivian Darks, and also give a shout out to my fellow health committee members, Dr. Judy Banks and Rosalind Seawright. Judy Banks will introduce Dr. Chris, and I will do a short introduction for Christine Ivory. And I believe Christine Ivory was with us before, and she will share a good update on Black maternal health. Christine Ivory is a Prematurity Prevention Initiative Project Director for the Southern New Jersey Perinatal Cooperative. She is dedicated to addressing and mitigating issues of Black infant and maternal mortality. Her passion is to help all walks of life through disease and disparity prevention, as well as making an impact in the communities she serves. She secures successful implementation of the program objectives and cultivates networks with maternal healthcare stakeholders to effectively address barriers that affect birth outcomes. I do know that Ms. Ivory has been working in the Atlantic County area on Black infant and maternal health project in the Atlantic County area and also in the Newark area. Christine serves as chair of the Public Health Youth Leaders Association in Philadelphia, chair of Sisters in Public Health, the Philadelphia chapter, Community Health Planning and Policy Development Section counselor for the American Public Health Association. She is a proud member of the American Public Health Association Philadelphia section on public health and preventive medicine at Drexel University Center for Black Culture Advisory Board, and the Greater Philadelphia Norfolk Alumni Chapter. She is also a proud member of Alpha Kappa Alpha Sorority Incorporated. Christine?
Wow, Deborah, thank you so much for a wonderful introduction. Thank you, Deborah, and also a good friend and colleague of mine, Crystal Sibley Charlie. I'm really glad and elated to be here today. And I first want to say thank you to the New Jersey NAACP State Conference for having me here today to speak about topics so critical around issues that affect our communities, Black infant and maternal mortality. My name is Christine Ivory. I am the project director for the Prematurity Prevention Initiative that's under Family Health Initiatives, which is a subsidiary of the Southern New Jersey Perinatal Cooperative. So today for our presentation, we're going to be talking about Black infant and maternal mortality, some foundational knowledge around it. I know a lot of us are very familiar with these facts, but maybe some not. So we'll be talking about Black infant health, and then we'll also be talking about a new tool developed by the the NAACP, Atlantic County Task Force, and we'll be talking more about that as well. But the presentation today is entitled Efforts to Improve Black Maternal and Child Health in New Jersey, and we'll be talking about the Maternal Experience Survey as well. Thank you. All right, so as we get started with this presentation, I first want to highlight a story that is very similar to a lot of stories that we have heard across our nation. It's about a woman named Kiera Johnson. Unfortunately, she died because of injustices. As we talk about institutional racism, as we talk about implicit and explicit bias, unfortunately, Kiera was subject to these things. And so we want to talk about this first and hear a quick under 2-minute video about her story before setting the tone and getting us started for today's presentation.
When Kiera and Charles Johnson first met in 2004, they planned to spend forever together.
Kiera challenged me to be a better person in every single aspect of my life.
They were overjoyed when they welcomed their first son, Charles.
He's so handsome.
Their second son, Langston, soon followed, delivered through a routine C-section after a healthy pregnancy. It was April 12th, 2016.
Hey, Langston.
Their celebration quickly turned to concern, though, when Charles noticed blood in Kiera's catheter. He alerted doctors, but says minutes turned into hours.
I'm begging, I'm pleading for them to do something.
Finally, he says, after 10 hours, doctors decided Kiera needed surgery, but it was too late. Kiera hemorrhaged to death. She was 39 years old.
Never imagined that I'd be sitting here today and that we would have left that hospital without my wife.
About 700 women die each year in the U.S. due to pregnancy or delivery complications, and African-American mothers are 4 times more likely to be victims than white women. Dr. Valerie Montgomery Rice says the causes of racial disparity aren't fully known.
I definitely think that there is a level of unconscious and conscious bias that occurs in medical settings.
Charles Johnson has turned his tragedy into action, helping to pass the Preventing Maternal Deaths Act, which became law last year. It requires states to review every pregnancy-related death. Charles' other fight, making sure his boys remember their mother.
The toughest question my sons have ever asked me is Mommy mad at me? Well, why won't she come home?
His answer, Mommy is in heaven and loves you forever.
I think Kiera's legacy will be one of being able to show people that regardless of the circumstances, that love always wins.
And Charles says his message to the medical community, listen to women when they say something doesn't feel right, Kate.
It's so heartbreaking. What can hospitals do?
Well, Kate, hospitals across the country are starting to develop protocols to deal with emergencies like Kiera's. In Cedars-Sinai Hospital in Los
Angeles. Thank you so much for those on the tech staff running our video in the back end. But I just want to really set the tone for our conversation today with Kiera Johnson's story. This is one of many stories that really tear at the fabric of our communities, that we know that this happens not only across our nation, but across our state of New Jersey, that women are not being heard, as we heard in the story, that it took 10 hours for Kiera Johnson to have the care that she needed. And at that time, it was unfortunately too late. And a lot of these circumstances continue as we talk about racism, as we talk about implicit bias, and all those different topics that are weaved in together. So we'll go to our next slide, but I just want to share one story around some of our themes. All right, so we also know that it's impossible to talk about Black infant and maternal mortality without taking a look at what happened in the past. So I'm just going to go through a very quick timeline of some injustices that speak to maternal child health and also people of color throughout time in health. So if we look at the top left-hand corner, we see a very picture that's common in some textbooks, actually. We see James Merriam Sims. He's known as the father of modern gynecology. James Merriam Sims owned slaves, and we can see a picture of one of the slaves, unfortunately, in the picture in the center. He did experiments on slave women. He did all different types of invasive procedures, surgeries, without giving any type of pain medication, of course, without consent, because he believed that people of color, that women that were people of color, did not feel pain. So this is just one of many injustices, but just to kind of set our timeline going back to slavery days. As we're going around kind of in a clockwise circle, we look at the next picture in black and white of a Black woman. She is breastfeeding a baby. This baby is actually her master's baby, her master's child. This term is called wet nursing. Happened very commonly, especially in slavery days. And we have this picture here, not just because it's injustice because of the women, but I'm sure that she actually is taking care of someone else's child and not her own, that she doesn't have the time to nurture her child because she's so busy nurturing someone else's. And then we're looking over here, going clockwise again, we see in the black and white picture, we see Henrietta Lacks. Many of us know this story. Henrietta Lacks went to Johns Hopkins University Hospital. She was complaining of bleeding, of different types of cramping and issues that she was having in her vaginal and cervical section of her body. Doctors did all different types of treatments and experiments, but unfortunately, Henrietta Lacks did die, but her cells were used in different types of experiments without her consent and also without her family's consent. And then lastly, at the bottom of our page here, we have the Tuskegee Experiment. We know that hundreds and hundreds of Black males were not given the treatment that they needed. That they had syphilis, many of the males, and were not given their treatment. Were also not able to write anything in consent forms, and a lot of injustices really done in reproductive space, but just for people of color is what we want to kind of set the tone with on this slide. So on our next slide, we are looking at some stats around maternal mortality. That's also known as a woman dying during pregnancy or after giving birth. So looking at these numbers in the whole nation, we'll see that there are trends going from all the way to the 80s, from 1987 all the way up to 2016 and beyond. It's really shocking to see these numbers increase throughout the years, but one thing that's even more alarming, as we look at the right-hand side of our chart here, we know that these disparities are really impacted disproportionately for Black women, as we can look here and see it in bold, that Black women are about 4 times more likely to unfortunately die from birth or pregnancy-related complications compared to their white counterparts. Next slide, please. So on our next slide, once again, looking at a view from a national standpoint, we see the impact of racial disparity on maternal and child health in our nation. So Black mothers are 3 to 4 times more likely to have a preterm birth. A preterm birth is a baby that's born before 37 weeks. And we know that when babies are born early, they're unfortunately more likely to die before their first birthday and may face a lot of challenges throughout their lifespan. We also know that Black infants are more likely to be born of low birth weight. Black women are more likely to lose a baby due to stillbirth. Hispanic and Black mothers are twice as likely to experience infant mortality. Once again, that's a baby dying before his or her first birthday. And unfortunately, pregnancy-related deaths are 60% preventable for Black mothers in the US. Next slide, please. So as we look at our next slide, we see that these numbers right here in front of us are narrowed down to the state of New Jersey. So looking at from 2009 to 2013, our statewide maternal mortality trends, we see that there is a high extreme number of pregnancy-related deaths among people of color, Black birthing people. We see that white women are represented in blue. We have Hispanic or Latinx women represented in green and other races in yellow. But this big half of our pie chart is represented by women of color, by Black birthing people. And we know that there's something wrong when we look at this chart and we see that there is a disproportionate number of deaths among, compared to different counterparts. On our next slide, we see really a repeat of what was on our last slide and the theme throughout. This one is more localized in thinking about the state of New Jersey, but for infant death. So if we follow this pink line at the top of our screen, we see that there is a high number of infant deaths compared to counterparts, once again, particularly when we look at white counterparts. We see that babies of color are about 3 to 4 times more likely to die before their first birthday. And we also want to note on this picture that there is a gap in between that blue and that pink line that does not look like it's closing anytime soon. Next slide. All right, so we're going to shift gears and talk about the Black Infant and Maternal Mortality Task Force. This task force started with the NAACP Atlantic City chapter. And after knowing and wrapping our minds around all these things and how to address these things and link arms all together, we formed the Black Infant and Maternal Mortality Task Force. So the purpose of the task force is to build a community level action response to the social and birthing injustices in New Jersey. And then underneath here in gray, we have our goals. The first was to develop a birth experience survey driven by Black women as a center of storytelling. And we'll be talking about the maternal experience survey shortly. Another deliverable or object that we worked upon was to provide a resource easily accessible to women, partners, birth workers, community organizations, political leaders, government institutions, anyone who was really interested in being a stakeholder and wanted to know how to help and improve their communities around Black infant and maternal mortality stats. Next slide. All right, so more about the maternal experience survey. What is the maternal experience survey? So the maternal experience survey is a community tool developed and designed to improve care to reduce childbirth-related disparities for women of color. And as I said, this was really created, took a lot of time with the NAACP Atlantic City Task Force as we crafted this tool. And next, it allows women to share their birth experience in safe manners, embedded with identity, acceptance, and respect. So we like to also capitalize on this word here, respect, that some of these women are sharing their story for the first time, have been unheard, have been silenced, possibly their whole life, and they're really sharing their story for the first time, possibly, and we want to respect that and also just empower women, of course. All right, so I won't go through our whole timeline, but this slide just shows that there was so much that went into and continues to go into the maternal experience survey. We started our development of this survey about last summer, and have been working so hard on it throughout time, even up until now. We have launched a survey this year at the top of the year, and I'll be talking a little bit more about that. But in the meantime, in between, we see that we have focus groups here. We asked women how they thought about the survey, what their thoughts were, and use that information to make the survey even better. So there was so much testing, data analytics that have gone into the back end of the survey. So excited to share what the survey is all about with everyone here. All right, so about the tool and the structure of use for the survey, it's divided into 3 sections. So birthing people, women throughout the state of New Jersey can take the survey on 3 different ways. The first is if they're pregnant. If they're pregnant right now, if they're in their prenatal stage, they can take the survey. They could also take it after they give birth. So we have a labor and delivery section to share your experience. And then last, we have a postpartum section of the survey. So a woman can share her whole experience, her whole journey from top to bottom. We also said that the survey is very user-friendly, and we considered languages and health literacy and just access as we were thinking about the survey. Third, here we, once again, user device flexibility. So let's say that a woman begins the survey on her cell phone. She could take a break and then continue back on her cell phone at another time. And then the survey is also available in English and Spanish. So we have those two language availabilities and thinking about other languages to include for the future. All right, so we're going to take some time and do a walkthrough and take a look at the maternal experience survey, just a quick tour. I'm going to highlight a few things as we're on our way and just show a couple things. So for our first page here, this is the first page that the woman will see upon entering the survey. The first thing that we greet her with is thanks and gratitude. We thank her for sharing her stories. We have respect to that woman's privacy. So that survey is confidential. She does not have to put her name or any type of identifying information. Also, I do like to highlight in the left-hand corner, your voice matters, your experience matters. Once again, we want to make this survey as empowering as possible so that she knows that her voice is being heard and that she can, feel strong, feel strengthened after she takes this survey. Next slide. All right, so one of the first questions that we asked is about the county. So which county is that woman residing in, or where does she live? Right now, the survey can be taken from any county. So if there's someone from Ocean, Camden, Burlington, Atlantic, whatever county is available right now for mothers and birthing people. Next slide. So next, after that, we have about you. We want to know more about that birthing person. We do have a space here at the bottom about putting in her ethnicity. She does not have to be or identify as a Black woman, so it can be someone that is Hispanic, Asian, white, anyone could take this survey, but of course we know that it is definitely for Black women. Next slide. All right, so on our next slide here, we have a drop down of where this woman was at for her birth. Did she have a birth? Did she have a stillborn baby, a miscarriage, an abortion? We don't want to come in and assume that the woman did give birth, so we want to acknowledge all different types of birthing stories. Next slide. All right, on our next slide, we asked if the woman received prenatal care, and if not, why did she not receive prenatal care? What type of barriers were in her way? Was she able to get insurance? Did she have childcare to get to her doctor's appointments? Was she able to make doctor's appointments? So all these different questions as we think about social determinants of health, and was the woman able to access everything that she needs? Next slide, please. All right, still thinking about social determinants of health here as we're thinking about transportation. Were there hours available for her to see her doctor, her physician? Was the doctor's office too close, or was it far away from home? All these different questions need to be addressed. Now, here are some important ones right here on the side. We asked here, did your race or ethnicity cause any negative treatment by your doctor, nurse, or midwife? So the woman will be able to fill in that box and say, yes, I believe that because of the color of my skin, there was some type of issue, or maybe not at all. I had a great experience. She can share what she likes right there. And then also underneath, do you feel like there was some type of negative treatment because of your age, your relationship status, your sexual orientation? We list out all those things. Next slide. All right, so thinking about if a woman raised concerns at her doctor's office, did she feel like she got the support that she needed? Did she feel like she was a collaborator in her health, and did she feel supported and cared for? These questions are so important to get to the story of, did the woman get the support and all the resources that she needed? Next slide. All right, and throughout the survey, there are portions where a woman can tell her story. She can type in a box and really share a little bit more about any concerns, any types of pregnancy scares maybe that she had that she just wants to share in these boxes to kind of let go and put it on paper, so to speak. So we have these boxes weaved in throughout the survey. Next slide, please. All right, and I love this section because it really paints a picture for how that woman felt. Did she feel like she was afraid when she went to her doctor when she gave birth? Did she feel confident? Did she feel respected, powerful? Really some words to describe her experience and then once again paint that picture in her story. Next slide, please. All right, another tell your story box. And I would like to also highlight that we have these pictures going out the survey to be relatable, to be warm, to, just not be all words on a screen. We want to, highlight the pictures too of Black and brown mamas. Next slide as well. All right, so as we're getting to the end too, we talk about the post-delivery portion of the of her experience. Was she referred to childcare? Did she need any type of chronic disease management, like for diabetes or hypertension, high blood pressure, anything for mental health? We asked about all these questions once again to see if women got the care that they needed. Next slide. Also in the postpartum stage, was there a follow-up being done? And this is a very important and critical time. We know that a lot of women face preeclampsia and all different types of complications after pregnancy. So the birthing process, the pregnancy process is very important, but after birth is so important and critical as well. Next slide. All right, just giving some more depth to that. We asked women if they experienced any type of excessive bleeding, headaches, fast heart rate. These are really some signs of some critical issues that can happen after pregnancy. So we asked about that as well. Next slide. Okay, so I'm going to try to speed up. I have a few more slides up. I'm sorry, I know I'm going a little bit over time. Our last slide right here of the survey is where the woman gets to show, or she gets to choose where she wants her story to go. She might say, I want to share it with everyone here on this list, legislators, hospitals, the NAACP, but she might say, I just want to keep the story to myself and just share it that way. So she has the opportunity to check as many boxes as possible. We'll go to our next slide. All right, so on this slide, we just want to highlight that Governor and First Lady Murphy are committed to helping to end health disparities around Black maternal health. And we'll go to our next slide, but Nurture New Jersey campaign, we just wanted to give a shout out there. Actions to take, there are so many actions. We know that with the maternal experience survey, that is one big action, but advocacy, looking at policy, promoting standards across NJ with hospital and health systems are so many different actions to take. And we'll go to our next slide. Lastly, if you would like to share the maternal experience survey, you could go to our website at njpreterm.org/MES. You'll find the survey there. So you can refer to any birthing people that you may know, people that are pregnant now, people that have just given birth, or in their postpartum section. So you can refer them to this flyer or to our website. We do have flyers for printout as well if anyone needs them. And I believe that's all. Let's go to our next slide. All right, so that's my information if anybody needs it, but thank you so much for your time. I'm sorry I went over a bit, and thank you again.
Thank you so much, Christine. I appreciate you. It's always a pleasure working with you. And you bring forth such great information, and you're making a huge impact on so many lives in New Jersey with the Black Maternal Initiative, right? So now I'm going to turn it over to Dr. Judy Banks, who will introduce University Hospital's own Dr. Chris Purnell. And she will start with her bio, and we will turn over the floor to you, Dr. Purnell. Thank you.
Good afternoon, everyone. It is my pleasure to introduce Dr. Purnell, and very excited to hear the message that she's going to deliver to the convention this afternoon. I know that Dr. Purnell is having a long day because I saw her at approximately 6 a.m. this morning on CNN. And I'm probably like a lot of people on this call during the past 18 months of the COVID pandemic. I spent a lot of time watching TV and televised media and the commentaries. And whenever I see Dr. Purnell's segment, I always stop and watch because I always want to hear what she has to say. She is an impressive speaker. She is a nationally recognized expert in her field, and she gives a great information And you can tell from her delivery that she is someone who is a caring and empathetic provider and who is an advocate for the community. I'm going to share with you some of Dr. Purnell's very impressive bio. Dr. Purnell is a dynamic physician leader and social change agent in her public health practice. She focuses on health justice, community-based advocacy, and population-wide health promotion and disease prevention. In November 2019, she joined University Hospital in Newark, New Jersey as the first Chief Strategic Integration and Health Equity Officer. She oversees a portfolio which includes population health, strategic planning, community affairs, and the human experience. Her office is responsible for leading health equity strategy and development and integrating equity and inclusion in a cohesive fashion across the organization. Dr. Purnell is a charismatic and leading voice in preventative medicine and public health. In 2021, she received a American College of Preventative Medicine Ron Davis Special Recognition Award for her work in the field of preventative medicine. Also in 2019, New Jersey Biz selected her as a public health hero. Known for spearheading work in greater Newark, New Jersey area, she was tapped to serve on the Essex County Civilian Task Force as a medical expert. Prison reform and care for justice-involved populations, along with issues such as evidence-based wellness programs, civic health, and high-quality education have been areas of her focus. Dr. Purnell is a honors graduate of Princeton University. She received her medical degree from Duke University School of Medicine. She holds a master's in public health from Columbia University Mailman School of Public Health and has completed a preventive health medicine residency at the prestigious Johns Hopkins Bloomberg School of Public Health. Dr. Purnell is a fellow of the American College of Preventive Medicine and holds an appointment as a clinical assistant professor at Rutgers, New Jersey Medical School. And she has previously been an adjunct associate professor at NYU College of Global Public Health. The NAACP State Convention welcomes Dr. Purnell.
Thank you very kindly, Doctor. You know, I really wanted to take this opportunity just to speak to everyone, talking about a topic that is inescapable. We have been living in the midst of a pandemic that is an unprecedented public health crisis. I don't have to tell you all of the numbers, but I will recount a few of them just to help understand the enormity of what we face. At this point, well over 650,000 Americans have lost their lives to the coronavirus pandemic, of which my father is one, 2 of my cousins are. We've had more than 41 million Americans test positive for coronavirus, of which my sister is one, and she actually has experienced long COVID at University Hospital. Our hospital was definitely at the epicenter of the first surge of the COVID-19 pandemic back in the spring of 2020. And that was the time that I likewise lost my father. We at University Hospital have been impacted in every way imaginable. We've lost workers, our colleagues, our peers. We've lost 12 workers at the hospital, and we speak their names and we shall never forget. Just like our communities have been devastated. And the reason why our communities have been devastated is actually pretty clear. What we're living in is the collision of multiple pandemics, and various speakers will say similar. I tend to term it as a fast pandemic, being the coronavirus pandemic, which ripped across the globe, leaving in its wake untold destruction, death, and disability, and the collision of systemic racism. Because of that collision course, we have seen earthquakes of devastation in Black and Brown communities disproportionately. Black and Brown communities are anywhere from 3 to 4 times more likely to be hospitalized because of coronavirus. Death rates are anywhere from 2 to 2.5 times higher than white Americans. And we see those similar disparities right here in our own state. And we all must acknowledge that. And it has to go beyond an acknowledging. It has to become an action plan for health equity and an action plan for health justice and racial justice. What is health equity? Health equity, as defined by the American Public Health Association and healthypeople.gov, is the opportunity for every person to achieve their highest level of health. Yet there are systemic barriers. There are political and structural and social determinants, how resources are grouped, how assets are geographically distributed, access to high quality education, access to competitive jobs with competitive wages, access to quality, affordable housing. And why do I point out those? I point out those because literature and research is showing that Black and brown people, Black people in particularly, experience what we have experienced during this pandemic because of those conditions that either raised our level of exposure, the risk of exposure, or contribute to why our communities and our family members and why persons in our social and familial circles have been burdened with chronic health conditions. Black and brown people are more likely to work in the service industry. Working in those service industries, I described they're on the front lines of the economy. And because they're on the front line of the economy, they often work jobs that they could not work remotely, or they work jobs where they did not have income protection, so they could not take time off. So they had high risk of exposure and high contact jobs. And then they went home to crowded, cramped residential quarters oftentimes. So they had high contact exposures in their households. And too often they were relying on, or our community is relying on, public transport. So again, the risk of exposure is higher. I tell you all of that because it's sobering when we begin to think about how do we untangle the web of structural and systemic racism, the web of socioeconomic factors, the web of chronic health conditions that have gotten us to where we are now so that we can get to high ground. I say high ground deliberately because I'm thinking of, and I want you to project an image of your mind of safety. And safety doesn't come by the action of one person. Safety doesn't come by the action of just one institution, but safety, protection, well-being is a collective action. So this is an appeal. This is an appeal to those of you who are in positions of influence and power to say, how can I use my agency to ensure that communities get to high ground? And this is an appeal for those of you personally and say, how can I, in my sphere of influence, ensure that those in my network get to high ground? And it starts first with an awareness. It starts first with an honest, authentic, and transparent knowing of what is at stake. So if you read the literature in one pantheon in the fields of preventive medicine and public health, and the fields of health equity more broadly, Dr. Kiera Johnson describes why we have the disparities that we have. You just heard the previous speaker, and kudos to the very, very full topic and statistics that were just shared with us around Black and infant, Black maternal and infant mortality, but disparities arrive because of differential access to care, the differential quality in the care received, and differential access to life opportunities. Those life opportunities are where you live. Those life opportunities are where you age, where you work, where you are educated, where you recreate and or play. And because of those systemic issues, we see the outcomes that we see. So in order to prevent or in order to heal those outcomes, those schisms, those broken broken areas in our system, we have to all understand what we're fighting against. So I start there because I can't talk about coronavirus without talking about racism, a system of structuring opportunity whereby one group is disadvantaged because of their skin color or their phenotype and the social construct of race. Another group is advantaged because of their skin color or phenotype or the social construct of race. But the society as a whole, our strength is sapped. And so when we have that level of understanding, we in institutions have to have that understanding. And that's how my office has approached the work of health equity at University Hospital. And as we have that level of awareness on the institutional level, we need that level of awareness on the individual level. And then to pivot and then talk specifically about where we are in the pandemic right now. I was talking about this the other day with workers at University Hospital when we were talking about the sense of fatigue, how so many of us are beleaguered because we've been fighting on the front lines or the forefront of a battle that has been waged for at least 18 months. And it has caused PTSD in many of the healthcare workers and others who have just been exposed to just the sheer destruction and devastation through the loss of life and disability. And what do we do to enable to continue to fight and persist and go forward? We have to know what's at stake and we have to know the odds. So where we are right now is we want people to understand how to keep themselves safe and how to keep their spheres safe. And that's going to first and foremost start around vaccination. This will be a multi-layered conversation, but it will start first and foremost around vaccination. Many of you may know, and others may be hearing for the first time, I enrolled in the Mrna COVID-19 vaccine trial. At this point, I have almost been fully vaccinated for 1 year. I got my first dose on August 31st. And of last year, 2020, and I got my second dose on October the 2nd. And so I'm coming up on a 1-year anniversary. At the time that I enrolled, I did not know whether or not I had received the actual vaccine or if I had received the placebo, because that's how those trials are done. But if you want to know why I did it because the work that I do is heart work. Preventive medicine and public health is as much a calling and a mission as it is a profession for me. And after losing my father, after seeing the devastation that our communities have experienced firsthand in our hospital, I needed a way to be a part of the solution. And I say that because as we begin to unravel inequities, that's one area where the inequities exist. The inequities exist around who participates in clinical trials. And it's not always just as simple as I choose to participate, but are there barriers to your participation, time and convenience barriers, cost barriers, information barriers, literacy and language barriers, social and cultural fluency barriers. So, you know, I've had many conversations around how do we increase participation given those barriers and given the truth of historical and contemporary injustices that Black people all too often have experienced, because too often science has become a tool of white supremacy. And I speak that plainly and clearly. And because of that, because of the sordid medical apartheid and histories that our previous speaker just went through, because of enslaved Black women being subjected to gynecological procedures without consent or anesthesia, because of Henrietta Lacks having her womb violated and tissue samples taken from which immortal cell lines have sprung up and have helped to contribute to scientific and biological breakthroughs, because of our Black men who were withheld treatment in the US Public Health Service study of syphilis, because of Black and brown women who have had to endure sterilization just because of a host of issues, because of things you've gone through personally, I've gone through personally. Our choices and our health-seeking behavior does not happen in a vacuum. And so a part of that struggle and battle must become, how do we begin to deal and display accountability for what has happened and what continues to happen. The issue of Black maternal mortality is a contemporary injustice and what continues to happen, such so that we can catalyze trust by first those of us in systems and institutions demonstrating accountability and trustworthiness. And so where we are now is I continue to have this conversation about the urgency to be vaccinated if you are not. And if you are not vaccinated, helping people understand what are the reasons they are not vaccinated, getting those questions answered, dealing with those deep-rooted topics, and ensuring that they have access, that ensuring that they have the opportunity to be vaccinated. Increasingly, we have mobile vaccine sites. University Hospital is doing a partnership with the New Jersey State Department of Health, and based off of that partnership, we have a mobile vaccine unit that goes into communities, specifically those communities that had not achieved a target percent of their population having received at least one dose of the vaccine. I'll put in the chat so everyone knows, but you should be aware that you can go to nj.gov Health's website. There is a COVID-19 dashboard. You can see how many people have been vaccinated to date. New Jersey has administered over 11.4 million doses. I'm reading to you now some stats. Over 6.3 million have had at least one dose, and over 5.7 million have had the full series and are fully vaccinated. If you break that down by race and ethnicity, approximately 8% of those who are vaccinated, or the population that's vaccinated, is Black, where we comprise 15% of the state's population. So there is an inequity there. So what must be done in the Black community in particular, that we match the rate of vaccination with our population share? The state is thinking about that. Institutions are thinking about that. NAACP is thinking about that. And many of you on the Zoom call are thinking about that. And that's part of the reason why University Hospital has gone into partnership with the mobile vaccine unit that has been in communities across New Jersey, whether Newark, whether New Brunswick, Trenton, or Camden, and ensuring that people have access to vaccines, and have access to vaccines from people who they trust, or in partnership with people, organizations that they trust, and that we use a prevention army. So community health workers to help neighborhoods and people in neighborhoods understand what's at stake, the risk, and how to get over or get to high ground and safety. And the last thing I'll say, and then we can have specific conversations, about the vaccine, about boosters, about Delta. We can talk about all of that, but I think it's this very general premise that I want us all to be on the same page about, because this is how we get to high ground. And finally, when we talk about a racial and health justice framework, what is that? And for me, that racial and health justice framework is one, that understanding of how disparities are created, the differential access to care, differential quality of care received, the differential access to life opportunities, to ensuring that we are building with assets in community that are considered trustworthy, that we are partnering and sharing power with those assets in community, that trustworthy, incredible messengers are mobilized and deployed in ways that we can have conversations that are authentic, and that we're using socially and culturally fluent language, socially and culturally fluent storytelling, and that the information that we share is health literate, that is plain spoken, that it's in the appropriate language or the preferred language for the audience and or health consumer. So that's where I'll leave it as the foundation, and happy to take any specific questions that you may have.
Thank you so much, Dr. Purnell. At this time, we would like to open it up for questions. We want to maximize our time because you will have heard it here first, right? So let's see, let's check the...
I only saw one question related to the elections.
Well, here's another one I see in the chat as opposed to the actual Q&A. It says, if someone has been vaccinated and had a breakthrough.
Okay, definitely. So let's talk about that. There's a lot in the news about boosters, right? The FDA advisory panel met yesterday. The first question that was put to the advisory panel was, should the Pfizer vaccine be approved as a booster dose, meaning people who are already fully vaccinated, as a booster dose for 16 and above? And the panel said no to that. The reason why the scientists said no to that is because we don't have conclusive evidence of a benefit of a third dose in the general population. The evidence that is building is in particular more clear, concise, and compelling around older persons. And this is evidence that from real world experiences in Israel versus what we're beginning to see in labs. So I wanted to start there to say, I believe that the FDA got it right, meaning that those who work in the healthcare environment, those who are older, so 65 and above, and those who are at high risk or have multiple comorbidities or frail, the FDA as panel has authorized through emergency use authorization the use of a third dose and i.e. a booster. Why do breakthrough infections occur, or what are breakthrough infections? Vaccines are not designed to prevent or prevent transmission of all disease. Vaccines are oftentimes designed to prevent severe disease, which is usually hospitalization, and to prevent death. That's how vaccines are designed. Because those are the endpoints or the outcomes of the vaccines, there is the chance that there can be transmission or spread and that someone can get infected. That is rare. The CDC has published data to say that the risk is over 11 times higher in unvaccinated for death, over 10 times higher for hospitalization. So we do see certain persons who have been fully vaccinated get infected, but typically they do not have the same experience as those who are unvaccinated. So if you are fully vaccinated, you are in most cases and scenarios safe. If you find yourself in a high-risk scenario, meaning you're indoors, it's cramped and it's crowded, please wear a mask. I wear a mask indoors regardless of whether it's cramped or it's crowded. And finally, if you find yourself outdoors and it's crowded, please put on a mask and try to separate, put some physical distancing between you and the crowd.
Thank you so much, Dr. Purnell. I did not see any additional questions, just double checking one last time. What is the okay, here's one just came in. What is your recommendation for vaccination in pregnancy?
Get vaccinated. Do you see how quick I said that? I can't, especially because of the issues we face around maternal mortality. If you just look at maternal mortality more broadly, the United States suffers worse outcomes comparative to other developed nations. Our maternal mortality is 2 times higher than if you drill down by race and ethnicity. Black maternal mortality is anywhere from 3 to 4 times higher. Given that baseline, pregnant women, those considering pregnancy, or pregnant people, or those considering pregnancy, please get vaccinated. What we know is that pregnant people have a higher risk of a severe outcome from the disease. There have been countless stories in the press of pregnant people who have had either successful C-section deliveries, but they have not survived. There have been other stories and documented through data of either some adverse outcomes for the unborn child as well, whether preterm delivery or fetal demise. So there is no risk to the pregnant woman for vaccination. You will experience the same side effects, the same chance of anaphylaxis is there, which is also very rare, but the risk of having a worse outcome from coronavirus is higher. So please, if you are pregnant or considering pregnancy, get vaccinated. And let me just say 2 other specific things to that, just trying to think through some of the disinformation or misinformation I've heard. The coronavirus vaccines are not live viruses. They do not infect you with coronavirus. 2, the mRNA nor the viral vector, which is J&J, coronavirus vaccines do not change your DNA. They do not. They do not change your genome. It is a genetic blueprint. It is a genetic recipe. It teaches your body how to make a certain protein. Because your body makes that protein, your body then mounts an immune response. Then your body gets rid of the proteins and your body gets rid of the messenger RNA. So those are just two things that I wanted to share.
Do we have more time for more questions, Crystal, Marcus?
You have 3 minutes.
Okay, there's another question on, did you see that one? What's Dr. Chris's take on ivermectin?
Oh, excellent. I'm glad that question came up. Do not take it. Ivermectin is an anti-parasite that has very narrow administration in certain infections. It has not been demonstrated to have any effectiveness or efficacy against coronavirus. So that's one thing. It's saddening and disheartening to hear how many of providers have prescribed ivermectin to people with coronavirus. If you are taking it over the counter in the formulation where it is not even meant for humans, but livestock, it is dangerous. You can have a host of side effects and you should not take it. What we know works in coronavirus infection is if you have moderate to severe disease and you're hospitalized, remdesivir. We also know about the use of IV steroids, so dexamethasone, especially if you're hospitalized and have a critical care unit stay. We know about the use of other drugs that are either like some of the drugs that work against the cytokine storm. I'm trying not to get too technical. Those drugs are worthwhile. And we know about monoclonal antibodies. Monoclonal antibodies are for those who have not been hospitalized but have tested positive within a certain amount of days. That is protective. It reduces the likelihood of you experiencing severe symptoms and the length of your symptoms. And finally, monoclonal antibodies are now approved for prophylaxis around exposure. So if you've been exposed to someone with coronavirus, those are the only authorized and or approved treatments for coronavirus.
Okay, so I know we're running out of time, so I'm going to just ask these two questions, and then Dr. Purnell, if you don't mind perusing the chat, I know you'll answer those chat questions because I've seen you do it. And so if you don't hear your answer out loud, I know Dr. Purnell will answer your question. So the two I want to ask out loud were the question around fertility. Does the vaccine affect fertility? And then to close us out for the questions, what can the NAACP in Essex County and statewide, what can we do to educate and inform to increase the vaccination rates across the state?
Okay, excellent. I want to be very, very clear on this and emphatic. The vaccines do not impact fertility. They are not able to impact fertility because that is not how the science works. These are mRNA vaccines. Basically, it teaches your body how to make a protein. So it does not alter any of your sex cells. It does not get incorporated into your DNA. And it does not impact pregnancy. It does not attack the protein that is responsible for the attachment of the placenta. And that was some of the original speculation. So there are no risks to pregnant people or no risks to people who want to consider pregnancy in the future. And finally, what can NAACP do? Continue to wield the advocacy and the action power that you have, meaning put before communities those trusted voices, credible voices who can decipher, translate, and break down what is happening and what is at stake. Continue to amplify the voices of our physicians and our physician scientists who come from the communities, that we are from, and continue to source socially and culturally fluent information, meaning how does this impact me in particular as a Black woman, as a Black family, as a Black man, as a brown person? How does that impact me because of my history, because of the disproportionate burden and risk that I bear and carry? And so continue to do that brilliant job that I believe you're already doing and partnering with the assets that are in community.
Thank you so much. With that, I believe, Deborah, you're going to do a formal closing out for the Health Committee. Dr. Purnell, thank you once again for answering the call and coming out and spreading the good word, the credible information, being the credible messenger that you are, because we really need you in this fight. If we're going to get over this, we need our credible messengers, everyone, like Dr. Purnell. Thank you so much. Deb?
Thank you.
Christine, Ivory, and Dr. Chris, thank you for your powerful messages this afternoon, and we had a good opportunity to engage with you, and we hope to see you again soon at our membership meetings. I know, Chris, I will be working with you in the Middlesex County area, and Dr. Chris has been visited the New Brunswick area branch. I think it was earlier in the year. So thank you.